Okay, in this video, we will be discussing about inclusion body myositis. It is an idiopathic inflammatory myositis. Means it is a kind of inflammation of the of the muscles, which is mainly autoimmune in nature. Right? It is autoimmune. Among others, like dermatomyositis, polymyositis, immune-mediated necrotizing myositis, inclusion body myositis is also a myositis, or it is also an inflammation of the muscle. These all are autoimmune in nature. IBM is also autoimmune in nature, but there are a few differences between the other myositis and inclusion body myositis that we will be discussing in the coming slides. As far as clinical features are concerned, see these images, they show the different clinical features, abnormalities or weaknesses of proximal and distal muscles. Let us see them one by one. First, figure A shows that uh, there is finger flexor weakness, right? It is written here, finger flexor weakness. It is mild weakness, it is more weakness. This thing B, it is more weakness. Myositis, now in figure C, it is very severe finger weakness or distal muscle weakness. See, in other myositis there is basically proximal weakness, means the bigger muscles like the muscles of the shoulder, muscles of the hips are involved. But in inclusion body myositis there is proximal as well as distal muscle involvement. Distal means small muscles of the hand, small muscles of the feet. They are also involved to a very great extent. That is why it is shown in here. Then the very important image is this E, in which there is atrophy of the vastus medialis muscle. The medial side of the thigh is very atrophic. It is the it is because of atrophy of vastus medialis, which is properly shown in here. This is the MRI of the thigh. This is the right thigh, this is the left thigh, right? This is humerus, and in here it is the vastus medialis muscle. This whole muscle is the vastus medialis muscle. Here it is normal, brown in color. You can see brown in color. But in this inclusion by body myositis, the later on the image is taken, there is complete fibrosis, whitish colored appearance on MRI. This is because of destruction of the muscles and replacement of these muscles by the fibrous tissue. That is why it is seen like that, right? Let us see what is written in here. Fibrous replacement of vastus medialis is there. This is the image from Harrison's textbook, so it is very important image as far as clinical features are concerned. That is why I am discussing it in this video. Now, one by one, if we see the clinical features, first of all, age over 50 years, very important. In dermatomyositis, the age is younger individuals in dermatomyositis. So these are all the differentiating features. In polymyositis also there is, in polymyositis also there is uh, uh, the younger age group is more commonly involved. Then it is more common in men, again a differentiating feature. In other myositis, uh, the women are more commonly involved. Women to male ratio or female to male ratio, male female ratio, let us see it like that, is 1 is to 3. Females are 3 times more commonly involved. But in this uh, inclusion body myositis, men are more involved than women. Early involvement of the wrist and finger flexors in the arms and quadriceps in the legs, right? Finger flexors in the arms and quadriceps in the legs are involved. Weakness is asymmetric, okay. Dysphagia is very common. That is why we have to, give some vocational or lifestyle exercises for them, for the patients to improve. One of those exercises for the purpose of dysphagia. These clinical features help distinguish IBM from polymyositis. There is no known increased risk of malignancy. See, in dermatomyositis there is increased risk of malignancy. Which cancer? Colonic cancer. But in this inclusion body there is no risk of increased malignancy. Right? Next slide. Laboratory features. See, very important is CK levels, which can be normal or very slightly elevated, whereas in other myositis like dermatomyositis or polymyositis, these CK levels are highly elevated, 100 times more, 1000 times more elevated. So that is a major difference. Very important to understand is the antibody. The antibodies target cytosolic 5' nucleotidase 1A, short form CN1A. Very important. It is seen in many, more than half of the IBM patients. There is CD4 to CD8 ratio is reduced, right, and CD8 count is increased because of these antibodies. They, kinda, there is involvement of cellular and humoral immunity, right. Autoantibodies are formed as well as CD8 cell are directed towards the self antigens. Muscle MRI may show predilection for involvement of flexor digitorum profundus in the arms and vastus medialis. We have already seen the image of vastus medialis. Similarly, in upper limbs, flexor digitorum profundus is involved. Right. Sparing of the rectus femoris muscle, that is also important. Then there is histopathology and pathogenesis. Histopathology. CD8 cells, macrophages. They will cause inflammatory infiltrates and non-necrotic muscle fibers. Right. Inclusions, very important. Inclusions, we are studying inclusion body myositis. What are the inclusions? Inclusions contain amyloid, right, but we cannot see it with the regular congo red. We have to stain it with P62. Importantly, there is also rimmed vacuoles, right. Rimmed vacuoles means there are vacuoles, empty spaces, and there is inclusion bodies. Such is the pathology image in inclusion body myositis. If we see the image, this is the image from Harrison's. These are the rimmed vacuoles, right? These are the muscles, individual muscle fiber, right? These are the rimmed vacuoles, and these are the inclusion bodies. Let me remove these markings again. These are the inclusion bodies, these are the rimmed vacuoles, right? And these are the cells, maybe inflammatory cells, right? This is a particular stain of the muscle fibers. Which kind of stain it is? It is cytochrome oxidase stain. It shows COX negative muscle fibers. These are the pale muscle fibers, they are COX negative, right? This is the inclusion body. Which stain it is? Let me see. P62, which is used to stain. Normal Congo red will not stain this amyloid. We have to use P62 stain. Now this is the electron microscopy image. There are these microfilaments, right? These are seen, these are the inclusions. Treatment. See, IBM does not typically respond to any known immunotherapy. The mainstay is physical and occupational therapy to improve function, and swallowing therapy is also given, that I was discussing in the previous slide. There is swallowing therapy also, and sometimes esophageal dilation we have to do, or sometimes we have to do cricopharyngeal myotomy in those with dysphagia. Right, this is the treatment. No immunotherapy is working, we have to give occupational therapy, physical therapy, swallowing therapy, or we have to do various surgeries for correcting dysphagia. Prognosis. slowly progressive, but within 10 to 15 years the patient is totally bedridden or wheelchair bound. Wheelchair bound by 15 years max, right? So this was all about inclusion body myositis. Let us revise it once again. Clinical features: distal muscles, these are the proximal muscles, relatively proximal muscles. Vastus medialis being replaced by fibrous tissue. Clinical features: 50 years, males, मतलब old and males. Quadriceps in the legs are involved, finger flexors in the arms are involved. Asymmetric weakness: dysphagia is common. We have to differentiate it from polymyositis. There is no risk of malignancy, no risk of cardiac involvement, no risk of ILD, right? ILD cardiac एंड सी है, नो रिस्क, इन तीनों का कोई रिस्क नहीं है इसमें. हालांकि डर्मेटोमाइसाइटिस पॉलीमाइसाइटिस में रिस्क है लेकिन इसमें नहीं है. लैब फीचर्स: सी एन वन ए एंटीबॉडी, सी के लेवल्स नॉर्मल, सी डी फोर सी डी एट रेशियो रिड्यूस्ड, सी डी एट इंक्रीजेस, सी डी एट काउंट्स इंक्रीज, राइट? That is done MRI findings. HPE, histopathology and pathogenesis. Histopathology, we will see uh, CD8 cells and macrophages infiltrating the muscle fibers. Inclusions contain beta sheets of amyloid which do not stain, difficult to appreciate with Congo red. We have to do staining with P62, right, to see them. Importantly, there are rimmed vacuoles also. Rimmed vacuoles are empty spaces in which there are inclusion bodies. These are the images that we have discussed. Treatment: no immunotherapy, only physical, occupational, and swallowing therapy. Prognosis: slowly progressive, not responsive to drugs, and patient is wheelchair bound within 15 years. That is all about this inflammatory myositis or inclusion body myositis. The other remaining myositis, I will be coming up with the new videos. That's all. Thank you.